Hartford Healthcare. Thank you for joining us for our monthly Walk to Wellness at Westbourne series. We hope you find this session informative, and I really am very excited and have the pleasure of introducing our speaker today. His name is Dr. Derek Smith. He's a board-certified neurologist with the Hartford Healthcare Eye and Neuroscience Institute Multiple Sclerosis Center. So thank you, Dr. Smith, for being here. I'm going to turn it over to him, and you'll have time at the end of the session or during to ask some questions. So thank you again for being here.
Thanks, Nadine. I'm told I can take my mask off, so hopefully I can identify that. But I'm fully vaccinated, and so thanks for coming out this morning. Thanks for letting me be part of your special group, which I guess is mall walkers. And I just want you to know that I walked almost all the way around the mall in order to find the door to get in here. So maybe I could be like an honorary member or something. So some of you got cups of coffee, so I'm not going to do the show of hands thing. But what I specialize in and what we have developed at Hartford Healthcare is multiple sclerosis. If there's anyone that does have a free hand and has never heard of MS, raise your hand, because I'd be interested in, okay. So everybody has at least heard of MS. MS used to be considered a rare disease, and we've sort of figured out that it no longer is a rare disease. It tends to be a young adult disease, and hits people usually in their 20s and 30s. And then once somebody's diagnosed, it can continue to affect them for really decades. And it's a disease that I think a lot of people used to fear. I think that's one of the reasons it wasn't diagnosed as early as it probably should have been or could have been in the past. But the really good news is over the past few decades, we've gotten newer and better therapies almost every year. And now it's a disease that I tell people when you're diagnosed, we can generally bring it under control. And depending how early we catch it, people may be able to live with it without significant disability, but there's still a lot of people with MS that have a significant amount of disability. And I'll talk a little bit about how it happens. And sometimes that disability is not obvious. So just since we're talking about mall walking here, good morning. You know, one of the things that happens to people with MS is maybe they're able to walk, but they can only walk a certain distance before they have to stop. Whereas like you guys can probably just keep going for hours. A lot of people with MS are severely limited. And they develop things like spasticity, which is muscle stiffness, which can interfere with sleep. So what MS basically is an autoimmune disease. So in that sense, it shares a lot with something like rheumatoid arthritis. So in rheumatoid arthritis, the immune system attacks the joints. In MS, the immune system is attacking the central nervous system. So that's the brain and then the spinal cord. And the central nervous system is not really designed to handle inflammation. And so it doesn't heal well if there's an immune response within it. And so what MS actually means is multiple sclerosis. It's basically a French word for multiple scars. And that's very accurate. What you see in people with MS is multiple scars in small locations, usually throughout the central nervous system. And there is some retention of normal brain tissue, generally within those scars. But what you'll see is a loss of an insulating layer around the nerve cells. That's called myelin. So sometimes you'll hear MS described as a demyelinating illness. And the effect of losing that myelin layer is that the nerve cells still work maybe, but they don't transmit nerve signals quite as quickly as they used to. So we now think that there's around 1 million people in the United States with MS. Whereas if you look at the old numbers, when I started, which is a quarter of a century ago now in the MS world, it was more like 250,000. So we now think there's 4 times as many people with MS as we used to think. There's a lot of reasons for that. One of them I mentioned is that we're diagnosing earlier because we have effective treatments. And one of the main reasons we're able to do that is MRI scans. So even if you get a CAT scan, which is a very good study of the nervous system, for example, it's an X-ray. You generally don't see MS. You really need an MRI scan in order to see these scars that I was talking about. And because of wider use of MRI scans, we're able now to diagnose it earlier and better. And it's predominantly a female illness, so 2 to 3 times as many women as men get it. We don't really know why that is. And it's thought that it's an effect of some of the female hormones like estrogen on the immune system. But that's also true for other autoimmune illnesses. And generally people who get MS are people who don't get sick a lot. A lot of people think that there's a problem in the immune system, but the problem may be the immune system works too well. And so a lot of the treatments that we have for MS are designed to slow the immune system down, essentially. And we have various ways of doing that, but we want to do it in a safe way so that there's not a lot of other consequences to that. So in terms of the treatments, the initial treatments were all injections, and people had to self-inject, and nobody liked doing that, and everybody who did it for a lot of years got tired of doing it, and the injection sites got red. But starting about 15 years ago, we started to get IV treatments, but then 10 years ago, oral treatments. And those treatments work at least as well as the injectables, if not better. And so we have gotten people to take medication for longer periods of time, which has also helped the outcomes in terms of people getting diagnosed with MS being well controlled. So, are there any questions at this point? Yes.
There's a bunch of families, because I have a niece and a great niece, both have it. And the great niece, she got it when she was in her 20s.
So we do have a lot of information about the genetics of MS. And that was really allowed by what was called the Human Genome Project. Hopefully everyone remembers hearing about that. But we, about 15 years ago, finished sequencing the human genome. So everyone said, that's great, now we're going to be able to figure out the genetics of all these illnesses, and MS was one of the first ones. Actually, one of the leaders of the Human Genome Project had a sister with MS, and so he went out of his way to recruit somebody to head up the effort to do the genetics of MS. And so the genes that are associated with an increased risk for MS are all immune system genes. And for anyone that doesn't know the immune system, the easiest way to think about it is white blood cells. So in your blood you have red blood cells, those carry the oxygen, and then white blood cells which travel around with them, and those are the cells that are really responsible for fighting infection. But it turns out when you look closely, it's not strongly genetic. So in identical twins, if one of them gets MS, if it was completely genetic 100% of the time, the other one would get MS. And identical twins usually grow up in the same house too, so they're getting exposed to the same thing at the same time. But 2 out of 3 times in identical twins, if one gets it, the other one doesn't. And even if they both get it, one can get it early in life and get it like a more severe version, and one can get it later in life. and a milder version. So there's a lot of random chance associated with it. But what it is it's more common than what we realize. So in New England, I don't know if your niece and grandniece are in New England, Alabama. So, and then there's other things about genetics that aren't clear because in different parts of the world, there's different numbers of neurologists and different numbers of MRI scanners. So in some places, there's probably more MS than we realize even now, just because people don't get diagnosed. So that was a long way of answering your question, but what can I say? I like to talk. So, all right, so let me talk a little bit about what we're doing at Hartford Healthcare. I joined Hartford Healthcare about 2.5 years ago, and then there's also a Southington Center with a number of providers there. We're in Norwich, and we're also starting at North Haven. And the idea is, people with MS can have mobility impairment. They don't like to drive at night, which in the winter, nights are long. And so what we're doing is we're setting up a network so that people with MS can be treated closer to where they live. And there's something called Hartford Healthcare at Home, which is a network of physical therapists, speech therapists, occupational therapists that are pretty much everywhere. And so we work closely with them. We have an infusion center in Norwich, and then we also work with various infusion sites throughout the state to give the IV medications. And so we were recently recognized by the MS Society as a partner in MS Care and as a comprehensive MS center as a system. So a lot of people with MS need a lot of other services too. So those can be a lot of things. We have social workers in our sites that can help because MS can affect employment and housing issues. And then just psychological state. Any chronic illness is going to be associated with some degree of depression and challenge. We have imaging in multiple sites throughout the state, and that's an important part, not just of diagnosing MS, but of also managing MS. And then various specialists are brought in. So we have rehab specialists that frequently are involved in rehabbing people. We have issues with bowel and bladder control are fairly common, so urology. And then because it affects young women, we're working on a partnership with Women's Health Network to better address reproductive issues in people with MS. A lot of times I'll get questions about MS and pregnancy, and we think actually that pregnancy itself is protective against people having attacks of MS, but then postpartum there can be an increased risk of MS. So there's a lot of management through all of that. We don't like using medications during pregnancy, so there's issues there. So that's it. I've been doing this for a while, so I don't know if there's any other questions. Yes? So if you look on any resource, it'll describe different types of MS. And those are commonly termed relapsing remitting MS, secondary progressive MS, something called progressive relapsing MS, and then primary progressive MS. But we've learned a lot, especially with MRI scans. And if you look at MRI scans, those different types of MS look more similar than different. And so those different types of MS are probably antiquated definitions that have to do with people seeming to have episodes of worsening and then getting better or not. And it is true that the relapses, so the episodes that usually come on over a few days and then resolve over a few weeks, those are more common in younger people, and they become less common with time. And then more as injury builds up over time, then people may have more chronic kinds of disability. So that's really the origin of those terms, but I think they're more misleading than anything else. And most of the treatments that we have are going to be effective against earlier forms of MS. And once somebody has more chronic forms of disability, it becomes harder to affect that. So a lot of the things that we do in neurology are designed to prevent injury and prevent disability. Because once somebody has a problem, it's a lot harder to fix that. And just about any neurological diagnosis that you can think of, stroke, Alzheimer's, once somebody has a problem, it's harder to fix it. So prevention is key, but we have been very good at doing that, in MS. Yes.
Why is the cold temperatures, people in North America, like cold regions, does that affect MS?
So there is thought to be a latitude effect with MS, and there's been a lot of sort of scientific kind of research about why that would be. And I think the consensus now is that it has to do with UV exposure and vitamin D. So UV has direct effects on the immune system. I don't know if you know anyone with psoriasis, but one of the things they'll prescribe for psoriasis is UV because that's an autoimmune illness of the skin, can also affect the joints. But direct UV onto psoriasis can help cure it because it decreases the inflammation. And so it's thought that both direct UV effects on the immune system, but also vitamin D production, which UV promotes, are both beneficial in terms of decreasing the immune response and being, let's say, too robust. And so people that live in higher latitudes where they're not getting UV year-round and maybe their vitamin D dips lower, seem to have a higher risk of MS. Getting back to what I was saying earlier, it's also true that the higher latitude countries are the ones with more neurologists and more MRI scans. So it may just be where we're looking, and I think the jury's still out a little bit on that. The other thing, if you talk to people with MS, they'll say they're very temperature sensitive, and that the heat bothers them a lot. Sometimes it's the cold, but usually it's the heat. And that they just wilt like lilies. And we don't really understand why that is, but a lot of what we do is to manage that is figure out ways to keep them cool. So sometimes it's as simple as an air conditioner. Another thing that we've done at Hartford Healthcare is we partnered with a nonprofit called American Families with MS, AFMS, and we're able to provide durable medical equipment, which might include something like an air conditioner that insurance doesn't cover. So that's been great because most people don't have a lot of extra resources lying around for things like that. Go ahead, you had a question.
Do people with MS tend to have a shorter lifespan?
A little bit, not a lot. So MS is more associated with disability than death. But for people that are very disabled, they can have problems with recurrent urinary tract infections, or if they don't swallow well, with recurrent pneumonias. And so those things can shorten their lifespan. And then getting back to the psychological aspects, people get depressed with MS, they lose their job, they get depressed. And so there's a higher suicide rate with MS too. Also a higher divorce rate. So, yeah. it's not just the illness, there's a lot of other things that we get into managing. So we need big teams, and, you know, one of the problems that's been true all along with MS care is a lot of the stuff we do, insurance doesn't want to pay for. But we have to do it, right?
About a little bit, I don't know if this was brought up, or I don't think it was, about the deep brain stimulation, and if you see any improvements with using that. Do we do that?
So deep brain simulators are very cool gadgets. And what they're primarily used for is Parkinson's disease. There's not an approved role for those in MS. In the old days, it used to be thought that some people with MS had Parkinson's, and those two diagnoses got confused sometimes. Usually we can tease those apart, but what's also true is there's nothing preventing people from having both MS and Parkinson's. And I do have a few people that fit that description. We do get into some medical devices with MS, so just to start off with, because of spasticity being very difficult to manage, one of the things we get into is Botox to treat spasticity, and then something called an intrathecal baclofen pump, which is a pump that's implanted into the lower part of the spine, and it provides anti-spasticity medication just to the muscles that need it in the legs. The problem with using oral anti-spasticity medications, it makes people tired. People with MS are already tired. So that avoids some side effects. There's a lot of other gizmos we get into, but deep brain stimulators, generally, we're not using it unless there's an overlap with Parkinson's. Okay. So if you know anyone with MS and they're not happy with their care, think about Hartford Healthcare. We've been building out our services, and have a good walk today.
One more question.
Yeah.
Is there a group of people who will be more vulnerable to this disease? Right?
Well, other than women, which is the biggest genetic risk factor by far, is having two X chromosomes. That's what makes one a female. There is a lot of interest in other genetic risk factors and in geographic distribution, which we talked about. But it's all complicated by the fact that this disease is diagnosed a little bit differently depending on where you live and on the availability of MRI scans, especially, but neurologists also. So that it's thought, for example, that there's a lower risk of MS in Asians. But if you look at Asian Americans, that's less true. So that I think some of that is just differences in the way that the healthcare system works, say in a place like Japan, where people don't tend to go to the doctor unless they're sicker. And so I think that it's remains to be seen how much some of these geographic differences are really the case. But it is primarily female, primarily young adult. It is thought that what triggers MS in most people is a viral infection of some sort, and I think a number of viruses potentially can do that. So I don't think that you can look at a specific, if you look for a specific virus that's doing that, that doesn't really narrow it down. But one of the things that I advise my MS patients to do is, to the extent that they can, avoid getting a lot of viral infections. Now, if you're, a grade school teacher that's dealing with a bunch of kids that are fighting viruses, that's next to impossible. If you're a bus driver, that's next to impossible. So there's a lot of different things that we do understand about the risk for MS, but we haven't been able to identify a cause.